On Health Matters Television for Life, heart health, and the one thing everyone should know how to do.
That's so important to have uninterrupted CPR.
How a new approach by the Spokane Fire Department is saving lives. Plus the high-tech device that allows citizens to step in and help.
They're all throughout Spokane and just waiting to save somebody's life.
From the risk factors to prevention, our panel takes your calls. Right now on Health Matters.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
One great thing about working at Providence is that I have the technology and the support for our type of complex patients. I'm Dr. Carl Garabedian, and I chose Providence because here I can provide the highest level of care to children of our region.
Find your doctor online at phc.org.
Good evening. I'm your host, Teresa Lukens. Heart disease is the #1 cause of death for both men and women in the United States, claiming approximately 1 million lives each year. So tonight, our focus is on heart health. On the prevention side, we'll talk about diet and exercise, and in the event of an emergency, what to look for and what to do when someone is going into cardiac arrest. A big subject and a superb panel here to answer your questions. So let's meet them. Andrew Boulay is a cardiologist with Providence Spokane Heart Institute. Jeff Markin is a family practice physician with Columbia Medical Associates. Keith Cottle practices interventional cardiology, and he is with Heart Clinics Northwest. And Ryan Schaefer is electrophysiology coordinator for Providence Sacred Heart Medical Center. And we are taking your calls and emails this evening. Please take advantage of our wonderful panel this evening with those calls and emails. And gentlemen, thank you so much for being with us tonight. It's really an important topic. It is Heart Month, and so there's a lot of focus on it. Let's start with talking about this muscle, this vital organ in our body that sustains our life. What are we talking about when we're talking about the heart and how it works? Dr. Cottle, why don't you begin?
Well, the thing that's unique about the heart muscle is that it has to work all the time. It can't stop at all, and that imposes some special requirements on it. The other thing that's unique about the heart muscle is that its vascular system, or its blood system, each has a specific area that it's responsible for. And the heart obviously is vulnerable to heart attacks, which are potentially fatal.
And those can come on in different ways, different forms of, cardiac arrest or heart disease. Dr. Boulay, talk about, what we're talking about when the heart can go into arrest.
There are a lot of different ways the heart can stop pumping. Sometimes it's an electrical short circuit. Usually that's the end result, but that can be initiated by a short circuit in the electrical system or from a heart attack, causing death to some of the heart muscle itself, and then it becomes irritable, and you can go into cardiac arrest for that reason also. There are other diseases of the heart that cause things such as heart failure. Weakening of the muscle could be from things like hypertension or prior heart attacks damaging the heart, or valve disease, which can wear out the heart muscle, which is built to last a good 100 years and yet can be overworked.
So a lot of what we want to focus on is the prevention of taking care of this muscle, the heart. And Dr. Markin, where do we begin? Is it as a child? I know a lot of people as adults sort of take advantage, take for granted our heart and how it works in sustaining life. And so we want to start early.
Well, in primary care, we do just that. We start, in the teenage years, identifying kids' risk factors, et cetera, and working with them to modify those from the get-go.
And a lot of that has to do with diet and exercise?
Absolutely. The more we can encourage people to change their lifestyle early on, and they develop patterns that are more sustainable.
What are some of those bad habits we get into that can really damage the heart?
Video games,
yeah,
TV,
sitting around,
sitting,
okay.
Overeating, of course. But my probable biggest focus is just on the activity part of their life.
See, We're designed to be really active most of the time and to get by on very few calories most of the time. That's our heritage, was a lot of work and very little to eat. And now that we have not much physical work to do and a lot to eat, we're not really designed for this. We're not designed for plenty.
And so, obviously, with lifestyle changes, we've got to make those changes in our life. We have to be very conscious of that.
As they've slipped away, exercise and proper diet from processed food, we get comfortable with that, not realizing the long-term effects. And we are now living a culture of the effects of the poor diet and exercise for many years, and you have to make a conscious effort to reverse that, because it's so easy to not do that, and yet that ounce of prevention is worth 10 pounds of cure. So we do encourage, we're pretty greedy as cardiologists. We like 30 to 40 minutes, 5 to maybe 8 days a week if you can give it to us, and doesn't have to be anything major, just walking or getting out for an easy bike ride or something like that, but more continuous too. A lot of people say, well, I'm active at work and it's 30 seconds at a time times 60, so that's 30 minutes, but really the heart circulation system likes to see a good 30 to 40 minutes 5 times a week.
Get that heartbeat up for a sustained amount of time.
Correct, and good research has been done on that. You don't need a whole lot more than that. You can do more if you enjoy it, but you don't need much more than that to get major cardiac benefits.
Just being active.
Yeah,
Yes.
and if we're not taking, oh, go ahead, Dr. Cottle.
I think people misinterpret their busy work for exercise also.
Yeah.
And really, and you guys could agree that exercise is in addition to your work schedule. Get something in addition to just a busy work day.
Ryan, I want to talk about what you do specifically, because you come in the event that something, that an event takes place. If we haven't taken care of our heart and that muscle, we have a cardiac arrest. Talk about what you do in your role.
I'm the coordinator for the electrophysiology program for Sacred Heart, which is essentially, it's a cardiologist that specializes in the electrical portion of the heart. I work under 9 physicians in Spokane. There's 9 EP docs in Spokane. They are partners of these guys, and they specialize in arrhythmias of the heart. They perform ablations, and we help identify patients that may be at risk of sudden cardiac arrest, and then put a implantable cardiac defibrillator in them to minimize the risk.
Oh,
also pacemakers and this kind of thing.
I was going to say, now how are the two different?
A pacemaker just works on a slow portion of the heart, so if the heart slows down, it will kick in and maintain a certain rate. And a defibrillator is really a shock box, or a shock to sustain life or interrupt a chaotic arrhythmia, life-threatening arrhythmia.
This might be a good place to talk more about CPR also, and we have an excellent piece done about the new form of CPR, which I think might surprise some of you, because some of us were trained many years ago in CPR. It's long been the standard response when someone is having a heart attack. It is still being used, but now in a new form. The change, along with some pretty amazing technology, is helping save lives, as we found out when we went to the Spokane Fire Department. No one wants to see one of these rigs roll up to their house, but in the event of a fire, Spokane firefighters have the tools and training to get everyone out safely. It's the same approach they use when someone is having a heart attack.
When the doors open, you'll see that aggressiveness from the point that the wheels start turning, just like you would for somebody trapped inside of a structure fire.
The Spokane Fire Department uses what's called a pit crew concept. That means 3 to 4 people just to do CPR.
To essentially bring the emergency department from a hospital to the patient's front yard, to their bathroom, into their living room, wherever the cardiac arrest occurred.
The idea is to have enough personnel on scene to rotate out every 2 minutes, keeping the crew fresh and giving the patient a better chance at life.
We've seen so much success with the pit crew philosophy and that type of technique that we've taken our cardiac arrest survival statistics from the low teens all the way up to 52%.
What's the location of your emergency, please?
And while the aid in the field is impressive, it begins long before the fire trucks arrive. Dispatchers are trained to talk a caller through hands-only CPR over the phone.
Our communication specialists are counting 1, 2, 3, 4, 5.
Another tool that is saving lives is the automated external defibrillator. These portable devices check the heart's rhythm and send an electric shock to the heart to restore normal rhythm. You'll find them in places like the Spokane International Airport, where they've been used 5 times in recent years to help someone in cardiac distress.
And they're all throughout Spokane and just waiting to save somebody's life.
And finding an AED in an emergency just got easier. All you need is your cell phone. The Spokane Fire Department's Pulse Point app will tell you where you can find the nearest portable defibrillator. It also alerts someone with CPR training of an emergency.
It allows the user of the iPhone, if they're close, to be notified of a cardiac arrest and then go respond and help that person.
The app debuted on Valentine's Day. It's free to download. And again, we want to let you know that that app is absolutely free. You can find it by going to the Apple App Store or Google Play. We also have posted a link with more information about the Pulse Point app. Just go to our website, ksps.org, and click on Health Matters. Pretty interesting stuff. Ryan, talk more about why the change in CPR. Why aren't we doing breaths anymore? Is this going to open it up to make it easier for people, I assume?
Well, that's the focus, is to make it easier. I mean, I think one of the, prevention of heart disease doesn't take place. We're talking about resuscitation or, having a plan of action. And bystander CPR is really one of the best plans out there. It's initiated by a witness, and really the first line of response is having a witness at that event that is willing to participate. And over the course of the years, the American Heart has changed the ratios of breaths to compressions. People felt confused about it.
And probably hesitated to do it.
Well, there was always that yuck factor with the the mouth-to-mouth. So they've taken that out, and hands-only is really easier to teach, easier to learn, easier to remember, and easier to perform. And so anybody can do it. They've had studies that even 5th and 6th graders can perform good compression CPR.
Wow.
When this came out, I just had one of these duh moments, because there's plenty of oxygen even in venous blood, the blood that's not circulating. What you need is circulating blood. Yeah. And every time you stop pumping to breathe, it stopped the whole thing. And we were doing that for a long time, and I guess it was Gordon Avey in Arizona that came up with it. He said, well, of course, why didn't I think of that?
Yeah. The Heart Association did a lot of research on that, and they even have a resuscitation society, and thanks to those people who worked on that they were able to show just what Dr. Caudill had mentioned, that there is oxygen, you just have to get it to the person. And they did enough elegant research that there's even 8 to 15 minutes. People argue over how long, but most of our EMS response is aimed at under 5 minutes to arrive. So if we can get someone to get oxygen to the tissues, which is really what the heart's job is to do via the blood, then they can survive without damaging organs such as the brain or kidneys or other things that are important.
Mm-hmm. And save lives. And the technology, the app that's available now, that's really something. What a great, useful tool for your phone.
Yeah. It really just is another tool in getting the awareness out there and having bystanders find AEDs and get to the side of a victim.
Mm-hmm. When it comes to this new CPR, do we all need to be retrained? Is this something we need? Because if we learned CPR 20 years ago, it is different. Are we going to have to go through some new training?
Yes, it's a good idea. Yeah. It's a good idea to refresh, even if you've been trained more recently. And there is information online that could demonstrate and educate you intellectually, but it's nice to have the resuscitation annies that they use to have you practice. So that
It's true, but it's way easier. Right. It's way easier than it used to be.
Yeah, I can tell that from just seeing how they do it now.
The key for practice is getting a firm enough compression, because it won't do to just push lightly.
It takes a lot of strength.
Yes, you want to actually cause the heart to be compressed between the spine and the front and the back and the sternum in the front, and you're pushing the sternum toward the spine to get that pumping action on the heart.
And that's why we need the rotation system, so that because you're going to get tired doing that for 2 minutes.
That's right.
Okay, let's talk about, there's a catchphrase that we hear, especially this month that it's Heart Month, know your numbers. Okay. What are we talking about, and what numbers do I need to know, and then how do I need to focus on those numbers?
Dr. Caudill?
Well, I don't know how to answer that anymore, and I kind of thought this would come up tonight because the recommendations for what to do about one of the numbers, cholesterol, has changed dramatically just this past fall.
As has blood pressure numbers.
Blood pressure has changed, cholesterol has changed. Now, one thing hasn't changed is awareness of whether or not you have problems. So let's start with cholesterol. I guess for the sake of whether people need medicine, the bad number right now, if you have no heart problems at all, is 190 for the LDL or bad cholesterol. You can remember LDL and HDL because you want your LDL low and you want your HDL high. And so right now people are supposed to get medicine according to new recommendations if their LDL is above 190 if they don't have other problems such as diabetes or previous heart disease or some other things. So that's one number. Diabetes awareness is important too, but I'm not sure what number we tell people now. What do we tell?
Well, one of the key things here is to first of all get people established with a primary care physician, get them some longitudinal exposure to their doc. Those are the docs that start this process. They start the assessment. They do the risk profiles. They find out, you know, people's numbers with their annual physicals, and they can start to counsel and guide these patients to modify those risks. The diabetes thing's huge, you know, it's epidemic and partly a byproduct of our culture and not exercising and weight and all of those things. But, you know, we want to identify them, and anymore I see a lot of pre-diabetes. We're starting the interventions early before they ever become diabetic. And if they don't, you sort of watch the progression, 5-10 years, then they've got the disease.
So
And,
is it as much about knowing your numbers as it is sort of at least putting the focus on those numbers? Not so much, you know, well, I shouldn't say putting the focus on the numbers, but your health, putting the focus on your health.
That's it. You know, you use the numbers as a springboard to start initiating behavior change, lifestyle modification. And you counsel people and you work with them and help motivate them to change behaviors.
But I imagine you also find that it takes an event before people are willing to change, and in some cases still don't make those changes.
Often that's
Sometimes.
the case. Yes.
Sometimes. Again, I think having a longitudinal relationship with people helps. You know, seeing them on a regular basis, you know, working with them. And you know, there's a lot of barriers to behavior change. Too busy, no time at work, et cetera. And so focusing on identifying those barriers and where their motivation level is and helping them work to change those things.
We also need to talk about the differences between men and women, because symptoms will present differently in men than they do in women. And finally, we're you know, noticing that here in the last several years, that we're finally, you know, saying to women, your symptoms may not be the same as your husband's. Mm-hmm. Let's talk about those differences. First, for a man, what if they're starting to have a cardiac arrest or an event, what can be taking place? What should they start to notice?
I think that when you're having an acute coronary event, a heart attack, that may lead to a cardiac arrest, you want to get care quickly. And we look at chest pain as the classic thing. And we use the word pain, and there are a lot of people who don't like that because sometimes it just hurts somehow, or it's uncomfortable.
Or it's pressure.
Pressure,
Mm-hmm.
tightness, squeezing, something in the chest that shouldn't be there. Sometimes associated with shortness of breath, breaking out in a sweat, sometimes radiating to your jaw, your arm, or your shoulder. Those are fairly typical, brought on by exertion and relieved by rest. But many people with coronary disease, plugging up of the arteries, will have symptoms that don't have all of those, or sometimes not any of them. And just as a vignette, as a first-year fellow in cardiology, I called the surgeon one night because they had admitted someone for a heart attack who had chest pain, who really had a gallbladder. And he said, well, I'm glad you called because they admitted someone to me with a gallbladder who has a heart attack. His pain for his heart attack was in his stomach. Mm-hmm. And it took the surgeon just about an hour to figure that out. And so we traded patients. And early on, we learned, you know, you don't always have the exact same presentation. Yeah. The nerves on the inside are a little dumber than on the surface. Here, if you touch your hand, you know you touch there. On the inside, they come together, then they go to your brain, so your brain doesn't know, where'd that come from? It's somewhere in your chest or somewhere near there. It's all it can tell you. It's not a specific thing.
Yeah, that's important because the radiation to the arm or jaw, people sometimes think that there's something wrong with their arm or jaw, and basically it's a lot like a kid that didn't really study for the exam. I'm going to make something up here. I'm going to say arm. And that's basically what the brain is doing.
Well, because nobody wants to believe they're having a heart attack.
Well, but your brain cannot
And it doesn't
process
process
heart
it.
pain.
Okay.
It
Isn't
has
it
no
true
way
too that women tend to be a little more atypical in terms of those classic symptoms?
A little bit
Yeah.
more.
Presentation.
Sometimes nothing more than fatigue for women, but
Right.
that's true for men too. It really isn't true that men have one set of symptoms and women another. It's just that it's more common for women to have unusual symptoms.
But if as your arteries slowly get worse, your ability to exercise goes down. And that's why I tell my patients, if you exercise, I'm a lot less worried about you. You'll know when something's not right. But when you have to be, if you're a couch potato and something has to be so bad that it affects you just sitting there, you're not going to have any warning system. I have no time to act, and you're already in an emergency. So exercise prevents, and it also gives you an alert system that something's not right. You may just not be able to walk up that hill like you used to. No chest pain, but something's wrong. You're not able to do what you used to for some reason. And you come and bring it to Dr. Markin, and you don't have asthma, and EKG looks a little funny, and all of a sudden you're seeing Dr. Cottle.
Yep. We spot.
And when do you hit the emergency room? If you don't want to overreact, but then you don't want to ignore these symptoms either. So when do you get that immediate help or call 911?
Any discomfort that's lasted more than 15 minutes and you're worried it might be your heart, you ought to. Now, having said that, I think it's about right that 10% of people who come to the emergency room for possible cardiac pain have cardiac pain. The other 90% don't, but we tell people, let us figure that out. We're going to have some false alarms. And then most of those where it is the heart, it's not a true emergency. They have time to, okay, here's some meds, go get a treadmill next week, and let's see how bad this is. So we just want to let us decide if it's an emergency or not. And short-lived symptoms aren't as severe to the person at that time. But if they're long-lasting and not going away despite rest, then you should let us check it out.
How much can we reverse with diet and exercise? Can we heal the heart muscle by changing our lifestyle?
Yes, and by attitude also. But the muscle can get damaged from lack of blood flow. The recovery does depend upon a lot of factors, sometimes medicines, but again, diet and exercise are the cheapest medicines available, but the most expensive because no one will do them.
And the best.
And the best.
Often the best.
By far.
And
Yeah.
so it is true, if you chose lifestyle or meds, you would be better choosing lifestyle over meds
far.
in most patients. But if you want to do the best, most people with heart disease need both at some point. Whether it's heart failure, the meds help that a lot. Lifestyle helps a lot too. Heart attacks from plugged arteries, you've got to know your numbers, your cholesterol and your blood pressure particularly. Your weight is another number to know, and know what it should be, and you can get that easily off the internet or your doctor's office when you see your primary care provider. So.
Okay. And of course, Dr. Markin, you work with some older patients. You specialize in some geriatric patients, and so this is a population that is just continuing to age. It's going to be larger in the next 10, 20 years. Again, is that you're going to see more patients presenting with heart conditions?
Absolutely, because they've had their disease longer, and it tends to manifest in those later years. The challenge with seniors oftentimes is to motivate them to move when they hurt. A lot of times they have some arthritis, or they have a bum hip, or whatever it might be, and they have to overcome that. And so we want them to start with low impact types of things, but still keep moving.
Get in the pool, something
and there's
like
lots
that?
of data on that now. Pool, recumbent bikes, things that are easy on their joints. Sometimes a little discomfort is okay. You're probably not likely to damage something further as long as you're doing low impact activity.
It's also a great way to get involved with group activities, and
For
you
sure.
mentioned attitude being a big part of this. That can help, especially with an aging population that tends to be closed into their homes.
It's a social thing,
Yeah.
and it can be wonderful for them to get out and be with a group, and it helps motivate.
All right.
And exercise is almost universally good. We talk about, what we typically think of as cardio exercise, but strength exercise is cardio too. And if you can't, if you have no legs, you can still exercise with your arms. It still counts. It's still important and still good.
All right. We have an email coming into the show that we want to take from Lynn. Lynn says, my doctor said that I had coronary artery spasms that caused me to have angina. He put me on medicine and the problem has gotten better. What are these coronary artery spasms and what causes them? It's an excellent question from Lynn. Thank you. Who would like to answer? Dr. Belay?
Okay, I'll take a shot at it. Dr. Prinsmetal described this a long time ago. So when you get heart pain, in this case from lack of blood flow, the lack of blood flow is not from a fixed blockage in the artery, but rather an artery that spasms. All our arteries have muscles in the walls, and they do this all day long, relax and contract. And if they over-contract, that's a spasm, just like anywhere else. And relieving that coronary spasm will bring blood back to your heart. So stress makes that worse. Sometimes you can't control it. We forget that the nervous system goes everywhere, and when the balance between relaxing and spasming is out of whack, then you can get into trouble. So some medicines help the muscles in the artery relax directly. Lower stress helps prevent that. So we come at it from different ways. If the spasm lasts too long, you can damage the muscle, but it's an unusual cause for a heart attack itself, but it can cause a lot of angina as your arteries spasm. So
is that painful?
As
Does
painful
the
as
patient
any
feel
heart
that?
pain.
Exactly the same heart pain as a heart attack.
And different from a palpitation, or
Yes.
what we call a palpitation? Okay.
Palpitations, that refers to a sense of your heart beating irregularly in some way.
Or fast.
Or fast, or slow, just something, sensation of your heartbeat. Most of us don't feel our heartbeats most of the time. So palpitations are when you do, and
Yeah, a little jolt there. Okay. Ryan, I want to talk about a project you're involved in too that in the area high school. It's called Project Atom. Talk more about that.
Well, Project Atom is a public access defibrillation program that that the Cardiac Foundation, the Sacred Heart, Providence Sacred Heart Foundation, help fund, and we go into high schools and make them aware and make them ready for a cardiac emergency. We help deploy an AED to their school and then set up an emergency action plan, help train responders there. And
Students?
Sometimes it's students, but mostly it's faculty. So there's a designated amount of responders within that school. We also help maintain that AED and then set up a process for them to inspect it once a month. And so when and if an emergency happens, they'll have some kind of plan on site or on that campus, and then hopefully have a better chance of success.
And this started, Adam was a young man, a teenager.
Adam was a 17-year-old athlete from Wisconsin, and he died from sudden death on the basketball court. And his parents and a local cardiologist, Dr. Stu Berger, started this Project Atom. And now there's 9 affiliates across the nation, and we're the farthest out west.
And do we have any numbers on, is this saving lives, changing?
Well, we have had about 3 saves here in the Inland Northwest just from our program. A direct save and then some indirect saves that we've had linked to Project Atom. And so it's been a positive thing. And I think it's more of a global thing. Within the school you have, say, 10 or 15 responders that have been trained in CPR and AED usage, and you have all these students walking by an AED and they hear Project Atom and they're aware of an AED, and then after school hours they disperse within the community. And so you get this multiplier effect of, they may be at a mall or a home or what have you, and they have a little more awareness of what cardiac arrest is.
Absolutely.
They have an awareness of how to respond.
Yeah, the more people that know, the better.
Yeah.
Absolutely.
And as a side effect, there is a move to make sure they train all high school students in CPR, hands-only CPR, at some point. The kids get exposed to that, and then they've heard about the AEDs, and the faculty have known about it. And that's just a side of the Atom project, is that now we have more interest in kids, And if you think about it, it may take a generation, but if you train every 15-year-old how to do CPR in 30 years, over half of the Spokane will know how to do CPR.
Yeah.
It just takes time.
We want to talk a bit about a sudden cardiac arrest. You're having a heart attack. We have an excellent piece of animation, and perhaps one of you can talk about what is going on here with the heart during a sudden cardiac arrest.
The electrical system keeps the heart beating in uniform manner, and when the electrical short circuits occur, the beat can become not regular but chaotic.
And that's why we're seeing those flashes.
Correct. The flashes, and the line there is not quite flat with no activity, but it's hundreds of little fibrillatory activities, so we call it ventricular fibrillation. And normal heartbeat pumps the blood, fibrillation basically wiggling of the heart, and it doesn't pump anywhere. And then eventually your heart dies from that and you go flatline, as the animation says or shows. It can happen as a result of a prior heart attack, or it can happen on its own. And when that happens, the electrical system's unstable for whatever reason. There are some genetic reasons and some unknown reasons. But that's where the work Ryan does comes in that defibrillators, if you can survive the cardiac arrest from getting your CPR early and getting to the hospital, then you can be eligible to get a defibrillator in case it ever happens again, because the one thing that's most effective to get rid of the fibrillation is a shock to the heart. So instead of an AED, you have your own personal EMS in your chest in the form of a defibrillator that could shock you if needed. And then we work hard, Dr. Cull and I, to keep you from ever needing to be shocked, and very grateful that we have a defibrillator in if you do need it.
Well, and I think that explanation and showing that graphic really shows how shocking the heart can bring it back when you see those actual little electrodes firing in there.
I think the general public misconceives a heart attack and sudden cardiac arrest. So they're two distinctly different things. A heart attack is more of the plumbing issue, and sudden cardiac arrest is more of an electrical issue. But they get them oftentimes confused.
So Ryan, when we have these portable units in public places now, how do I know when to use one then, if that's the case, if these are two different events? Can I harm someone by using it if I'm not using it, correctly?
You cannot really harm someone by using it incorrectly. There's no really incorrect way to use it. But the classic sign of someone that needs an AED is they are not breathing and unresponsive.
They don't have a pulse.
And
Okay.
so even today, the American Heart Association, for lay people, they don't even have to check for a pulse. If you witness someone collapse and they are abnormally breathing or not breathing at all and unresponsive, you can put an AED on them, and the AED will it will actually read the arrhythmia and only shock that rhythm.
Yeah, it's important to emphasize
important to
that
know.
CPR is really useful, but it's a stopgap for somebody that's actually had a cardiac arrest. And they need to be shocked if their heart is stopped. But you don't have to be afraid of an AED. The first word is automatic, and they really are smart machines. And they will not shock somebody if the rhythm is not ventricular fibrillation. They just won't go.
That's an excellent point. Then that's exactly what I was wondering.
And if the person you're looking at is responding to you, moaning that they have chest pain, they don't need an AED. They need an ambulance to take them to the emergency room.
That's the other thing.
They don't need CPR.
Right. If they're responsive in some way, don't do that.
All right, we have a number of phone calls we want to try and get to. We have Fran calling in from Calgary. Hello, Fran.
Hi.
Thank you for waiting.
Oh, that's okay. You learn lots every minute you wait and listen. I'm asking about the diets, the changing ideas about diets, heart-healthy diets, and if they could sort of address, other than the quote-unquote Mediterranean diet, what do they think is a heart-healthy diet?
Excellent. Thank you, Fran.
I'll start first, because I'm a fairly simple person, and the thing that we do in Western society, the States and Canada, is we just have too much. We have too much of everything. And the first thing to do for a heart-healthy diet is just to eat less, and then particularly eat less animal fat. And you can think of that in the forms of meat or cheese or things that come from animals and not from plants. If you just start there, with smaller portions and less animal fat, you're starting on the right direction.
All right, and then to take it...
Eating closer to the earth, less processed, and not too much of it. That is the basics. Fiber is very important.
Vegetables.
Yeah, there's so much information out there. It comes at us in every direction. You know, the internet can be our friend. It can also be our foe because we hear about the next great thing to come along. You know, one day we're told, eat oatmeal, and we're all eating oatmeal. And, you know, it really is. It's kind of overload sometimes. And so Fran makes an excellent point. Where do we start?
Yeah, almost any diet, particularly if you're trying to lose weight, almost anything that's uniform, that is balanced. All this, all that, or all the other thing, it's going to work in the short run. You're probably going to lose weight, and you're probably not going to stick with it, and in the long run, you're not going to be healthier.
I think that's a great point. You know, these exotic diets are hard for people to sustain. They may be enticing initially, and they might lose a few pounds, but they're not sustained. And so, you know, they try them, and they're great, but in the long run, it doesn't probably do them a whole lot of good.
Yeah, and we've often said on this show, stop saying diet. This is a lifestyle change.
Balance and lifestyle.
Balance and lifestyle.
And
all right. We have another.
To that point, the diet studies have finally noticed bringing it to the people is where it's at. You can't necessarily get a Mediterranean diet in someone raised in Nebraska on beef and potatoes. So you have to learn how to teach them what they can eat from their culture, whatever culture it is.
That makes a lot of sense.
Whether they immigrated from Russia or they live in Nebraska. You want to have choices. So learn about all the choices. American Heart Association has a diet that's been shown to be good. Mediterranean's good. Again, closer to the earth. You can mix and match to whatever you have available in your grocery store, but learn those things and then apply it locally, i.e. to your own household.
All right, let's take a call from Sherry in Spokane. Hello, Sherry.
Hello.
Do you have a question?
Yes, I have supraventricular tachycardia, and drugs don't seem to help except for the adenosine that I got in the emergency room. Is ablation a way to go, or is that the only way to go?
And Sherry, is that what your doctor's recommending?
Well, one of them is. Not everybody's saying so. Nobody knows what to do.
Okay.
So she's brought up a good point. There can be many number of arrhythmias, not just VFib. The top chamber of the heart is the atrium, and if a short circuit occurs there, it rarely causes death. And she mentioned supraventricular tachycardia.
Big name.
That's a big name, and we don't like saying all those syllables, so we say SVT. And those happen to be some of the easiest to cure with ablation. Don't know what she needs in her particular case. Medications work many times, but if they don't, sometimes the first med doesn't work, but you go back and try a different one. Sometimes meds don't work at all, and you either have to live with it or take the next step after counseling with your doctor. And the next step might be an ablation. First of all, you want to make sure there's no other causes, such as hyperthyroidism or out of balance electrolytes, so the doctor might check some blood work in that case. But if all things are in order and they've checked an ultrasound to make sure there's no structural issues at fault, such as a bad valve, that they fix the valve, then you are there with SVT, and you can treat it with drugs or ablation. Sometimes drugs don't work. Okay. Sometimes drugs work, but they're 25 years old, don't want to take a med for the next 60 years, so they get an ablation even though the drugs worked.
I'm going to share a little secret. We use a lot of words in medicine that are confusing, and it's not deliberate, but we know it's confusing. Ablation means to wipe something out. And there are uterine ablations for people who have endometriosis. In the heart, in general, what we're trying to do is find the bad spot, the spot that's generating or causing this or is involved in it. And then usually a cardiac ablation is using a little electric current or a radio current to just burn that, physically burn it, and to essentially wipe out that bad spot. But when we talk about ablation in general, it's extracting without taking it out. It's removing that, in this case, electrically.
Okay. Is that open heart, or can that you can go in?
Nope, this is through the vein.
Through catheters, and it's mostly overnight in the hospital, but sometimes early morning procedures home that night. It can be that benign.
Okay. Let's take another phone call. Marilee in Spokane. Good evening.
Hello.
Hi.
Yes, I have a question about a calcium scoring exam. I see that it's being offered somewhere, but you need to have a referring physician. What is the advantage of going through this, and is it X-ray or what is it done? And if you get a report that says that you have a problem, is it going to make any difference whether or not you know that?
Oh,
Mary,
excellent.
Do you have any heart trouble that you know of?
No, but they have listed criteria, and I fit just about every category.
Okay.
All right. So what is the test that she's talking about?
What do you think?
Well, you know, that's one of those variables that's, I think, down on the list in terms of focus. You know, it can be helpful sometimes in risk stratifying patients, but in general, I think there's many things that are a lot more important to focus on.
What does it test for?
It's the thickness of calcium in the
wall
vessels.
of the vessel.
Yeah.
And in this case, she's talking about a cardiac CT. And it is an X-ray, so you're exposed to X-ray. They're looking for calcium in the artery. The body deposits calcium in areas of inflammation. Plaque, in one sense of the word, is formed with an inflammatory response. If you have no calcium, you could still have plaque. Usually it's early and young. If you have a lot of calcium, it may only be 5% narrow in your artery and not clinically significant, since our arteries are twice as big as they need to be. So, but it does correlate. A high calcium score correlates with the probability of having some moderately narrowed arteries. And then you'd present that to your doctor, who would say, well, we need to see if they're significant, so let's get a stress test. And so if you're totally unmotivated to do everything that you need to do for your lifestyle, and that's the one test that if it's abnormal, you'll do it, then go ahead and do it. If you, whether it's positive, whether it's abnormal or not, we're still going to recommend maintain a proper weight, keep your blood pressure controlled, diet, exercise, go to your family doctor, get your cholesterol checked and treated. And that's what we recommend whether you have calcium or not. It's just a way to know for sure. If you have zero calcium, it is fairly reassuring for the short run. But it doesn't change our recommendation. Doesn't mean go out and buy a pack of cigarettes and go eat at McDonald's the next month.
No. To be fair, we all agree on this. This is a controversial thing in cardiology, and there are those that believe that calcium screening is a great way to screen people for risk and to motivate them to do the very things we're talking about.
Just another tool
if it's
to
a
get
tool
them to
that gets
level?
people to get going, then that's useful. But we all agree, we all feel the same way about it here. In general, I think everybody should be living a heart-healthy lifestyle, whether or not you yet have heart artery disease. And it's rare that I need a calcium screen to make that motivational statement.
Okay, we have an email from Cara. What specific diet and or supplements would you recommend for preventative measures for your patients? Examples such as omega-3 fatty acids, CoQ10, flaxseed, etc. Chia seeds are now out there. There's kind of, you know, what's the supplement or the herbal remedy this week?
There's been a huge marketing push in many of those things, and you know, once again, I think those things can be somewhat helpful, but they're really overblown in my view. I'd be interested to hear about you guys' opinions about that. But I think, again, if you look at bang for your buck, the biggies are things we've all been talking about. You know, stopping smoking, get active, you know, be prudent about cholesterol management, those kinds of things. And you know, less focus on the supplements that's going to save me from a heart attack, because I think that's overblown.
I don't recommend any.
Really?
And
not a single one?
That's most consistent with the most recent recommendations from the HA and ACC.
Okay.
They just have not been proven to do, I'm not sure that any's been proven to do help for the heart, with the possible exception of omega-3 fatty acids. But I usually recommend people eat fish.
Dr. Belay, do you have some thoughts?
That's about what I was saying. If you're eating a heart-healthy diet, you'll get the fiber, the effect of the flaxseed, you'll get the effect of the omega-3s, supplements in low dose if you can't balance your diet. But you can get those same things just from going up and down the grocery aisle. Well, maybe not. Staying around the edge of the grocery store and getting your
Stay away from the middle.
yeah, stay away from the middle. But the supplements, they'll take things out of context, saying that, well, Eskimos eat a lot of free fatty acids, so if you'll buy my bottle of free fatty acids, you won't have coronary disease just like the Eskimos. Well, we don't. That's a big leap there. I don't think that the omega-3s are harmful, so I tell my patients there's no data that it helps you. If you're wedded to it, you can keep buying it, but I don't tell people I recommended it. And if you aren't on it and you're asking me, do I recommend it? My answer is no, but if you start, I won't yell at you either. It's up to you. But so far, as a scientist, they've had a lack of ability to prove that they do much more than diet, exercise, weight loss, and keeping your cholesterol.
You guys are starting to sound like a broken record.
Well, we are.
There you go.
I'll tell you, there is something about this that fascinates me, because an apple a day does keep the doctor away. I mean, eating apples and things that are high in vitamin C and vitamin A, and the very things that are identified in supplements, it works. But when you take it out and extract it and put it in a pill form, take it out of the apple, it just,
not the same.
And you know what? I don't really know why. I don't know why the ingredients of an apple isn't as good as an apple, but it's not.
Mother Nature has something to say about that.
There you go.
Apparently
There's
so.
some wisdom there.
Yeah. We have another call coming in from Ruth in Spokane. Good evening, Ruth.
Yes, I'd like to know the relationship or the importance of potassium.
Very important.
All right.
As far as heart health is concerned, I'm speaking for myself.
Okay. Do you take potassium, Ruth?
Beg your pardon?
Do you take potassium?
Yes, along with yes.
Along with other things.
Well, it's recommended.
Yes.
It's prescribed.
Absolutely, yeah.
And I've noticed when I don't take my potassium regularly, I get a pain near my left breast in my chest. Now, and also the relationship of a high blood pressure to heart conditions.
Okay, Ruth, thank you so much for your call. Let's start with potassium. That can be a tricky one, because I know my own grandmother had trouble controlling her potassium levels, and they would shoot up or they would be completely depleted.
It's a very important electrolyte for your entire body, and it's very tightly regulated for good reason. Cells have membranes that let potassium in or let it out, and there's high amount inside the cell. There's a certain amount inside the bloodstream that's healthy. Too high will stop your heart, too low will cause arrhythmias, including VFib and SVT and anything else in between. And the heart muscle is not the only muscle that's affected by potassium, but so are your other muscles. She may be feeling muscle spasms, I don't know. Probably. But we like to keep the potassium in a healthy range, and your kidneys help the most. So if you don't have good kidneys, you need to work closely with your doctor to get that right range, which we can tell by blood testing periodically. So sometimes we give medicines that raise or lower the potassium, and we follow through, and if it's too low, then we want to give you a supplement. And there's been a lot of good data that, in her comment about hypertension, that blood pressure is harder to control if your potassium's too low. There are a lot of other subtle reasons for that. It has to do with potassium, calcium metabolism and the effects on the blood vessels and systemic resistance. But the bottom line is, if you can keep it in a normal range, preferably 4 to 5, normal being 3.5 to 5.5, then you're going to have very few adverse effects related to potassium.
Well, the reason why it's such a common problem is that a lot of the medicines we use, particularly for high blood pressure, make you pee it away.
Okay.
And so it is very common for people to have problems with potassium unless they have supplements. And nowadays it's even a little more subtle, because the water pills, they used to be separate, that are part of blood pressure medicines are often incorporated with other meds. So a lot of my patients don't realize they're taking something that wastes potassium or has them pee it away. It's a really important point.
The other part of that question was the high blood pressure,
Yeah.
and that's obviously a huge risk factor for cardiovascular disease as well as stroke. And so it's a major focus in primary care, and I know in the cardiologist's office, to keep that number under good control.
Yeah, I imagine you monitor that quite closely with
do,
some of your patients,
regularly.
the older ones especially.
Regularly.
We had a caller call in, actually just want me to ask, what is a stent and how does that work?
We'll give that to our interventional cardiologist.
That's what happens when we fail.
Okay.
Good answer.
We learned a long time ago that blocked or narrowed arteries lead to a lot of heart symptoms and heart attacks. And a very enterprising and adventurous fella in Atlanta figured out to blow up a balloon in an artery and expand the artery and open it up. The problem with just using a balloon in there, you blow it up, take it out, is that the artery would often collapse back. So a stent is a little, very thin wire framework that serves like a scaffold to stay behind and hold the artery open so that it doesn't collapse back. Stents have really dramatically increased our ability to not only open up arteries, but keep them open. And they really work very well. I guess two things I'd say about stents nowadays. One is a misconception. Many people think that they're temporary, and usually they're not. 9 out of 10 times a stent that's put in will stay open forever, but only in that spot. And so there is the potential for other arteries to have the same problem, and that's usually what happens when Bud had to go back for another one. It wasn't that that one collapsed or broke down or rusted or anything like that. It's that he wasn't doing the diet and exercise thing and kept smoking, and dang, he has another one.
And there you go, there you go. Okay, that's an excellent answer. Lori from Spokane calling into the show. Hello, Lori.
Hi.
Do you have a question for our doctors?
Yes, I do. This has been something that's been on my mind for quite a while. I take flaxseed oil supplement because I don't tolerate fish oil well, because it tends to regurgitate on me and I taste fish and I don't like it. And I also had a concern that taking fish oil, is it, or do I need to be concerned with mercury levels in that fish oil? And I can only afford to eat salmon once a week, and I can't afford the wild salmon. So these are kind of all connected. I'm trying to raise my omega-3s. I've changed my whole diet to plant-based. Very little meat. I do a lot of soy. And so I'm supplementing with the flaxseed oil, and I don't know if that's something that's worth my time, I should keep doing. If there's a secret, like the krill oil is better for me.
Okay. That's an excellent point, Lori, that you make, because, again, a lot of information out there with the different types of oils that are available, and it sounds like Lori is doing a lot of things right. It sounds like she's changed her lifestyle, and so she's trying to get more omega-3s into her diet. Is there anything she can change about what she said?
The oilier, not just salmon, but remember the oilier fishes in general. So, salmon tends to be on the high end, but, there's other oilier type fishes, mackerel. I don't know about tuna so much, but anchovies are high in omega-3s. And
what about the mercury concern that she had?
I don't know the answer to that.
I've looked that up a few times over the years, and I do think you need to know that there's not a lot of mercury. You want to know where they're getting their stuff from.
You would have to eat a lot of it?
Yeah. You want to make sure they're not getting their oils from high mercury sources, and I don't know how to find out reliable ones because it's not an FDA regulated industry, and that's the problem with
supplements. But what about
supplements.
the amount of fish that she's eating, because we know there are certain levels in fish?
Well, as a rough guide, mercury is concentrated slowly in fish. So again, as a rough guide, the bigger the fish, the more problem there is with mercury deposition. So you're talking about swordfish and marlin and tuna, the really gigantic fish, and not so much salmon. They don't live long enough to consume much mercury in general. As to fish after mercury in capsules, I don't know, because there's very little regulation of what goes into fish oil capsules. So it's not controlled by the FDA, and I'm never sure what's in there.
Okay.
And her whole diet sounds good, and this is where it's hard to sort out one particular thing. I suspect if she dropped omega-3s from the diet, having done everything else she's done, she would never notice much difference. And everyone's looking for that magic bullet, and it's really a lifestyle, and she's got it.
Yeah.
So she probably doesn't need that one little aspect of it, but she can, if she wants to continue, then the flaxseed was a good choice. She's well educated.
All right. And of course, we get back to that diet and exercise.
Right.
We also want to let you know that on Health Matters, we are committed to giving you as much information as we can on the Affordable Care Act. And here's a few key dates you might want to remember. The deadline to purchase a qualified health plan through the Washington Health Plan Finder website or the federal site is March 31st. That is when the 2014 open enrollment will end. November 15th is the proposed date for 2015 open enrollment to start, the closing 2 months later on January 15th of 2015. So note that the Washington Apple Health, the state's Medicaid program, does not have an open enrollment period. Individuals and families will be able to apply and complete their renewals throughout the year on the wahealthfinder.org website. And again, I want to thank everyone here for being here tonight. It was a great discussion, and I think we learned a lot, especially about taking care of ourselves and taking care of that vital muscle that sustains life, that keeps us up and running, and it's all about diet and lifestyle. We've got about a minute left. Let's go around with just one last thought from each of you, again, on staying heart healthy.
Again, it is a day-to-day thing, a lifestyle thing. It's when that has gotten behind you, we're here to help reset and have a positive attitude. Stop thinking I can't do it, particularly smoking. People enter thinking, well, I can't quit, and they've already defeated themselves. They have to imagine themselves as a healthy person, eating well and not smoking, and then manifest that reality.
That's excellent.
Don't set the bar so high that you try and fail.
Right.
Set the bar at a reasonable level and maintain it.
Mm-hmm. Dr. Cottle?
If you smoke and you try and you don't succeed the first time, try again. The odds for success go up, not down, the more you try.
All right, and Ryan?
I think the best thing is prevent heart disease. And if all else fails, you have to have a plan at home and learn CPR and know where the AEDs are in your community.
Be aware. Thank you so much, gentlemen. A great discussion this evening. And that will do it for this edition of Health Matters. Thank you to everyone who called or emailed with your questions tonight. I'm Teresa Lukens. We look forward to seeing you back here on March 20th when our topic will be tummy troubles. Thanks for being here.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
One great thing about working at Providence is that I have the technology and the support for our type of complex patients. I'm Dr. Carl Garabedian, and I chose Providence because here I can provide the highest level of care to children of our region.
Find your doctor online at phc.org.